Psychedelic therapy, one of the points you mentioned is that nothing's, in a lot of ways, nothing's changed in a very, very long time. Do you think that it will, or do you think that it doesn't need to, or why do you think a lot of the elements of the therapy part of it have stayed quite similar?
Yeah, that's a very good point. I think that things have not changed for several reasons. First of all, because it works. To have somebody in a couch and a couple of therapists or sitters, that is as safe as it gets. So it also provides some time for the therapist to go to the toilet if they need, and the person is never left on. So from practical reasons, it does work well. What it doesn't do so well is scale. As I was saying, if we do this on a sort of kind of peer-to-peer approach, that's great. But how to make this happen in a situation in which we hope that the public health system will pay for psychedelic therapy. So now we're seeing the need, and I've seen this internally in the pharmaceutical companies that I consult for. They are wondering, how do we do this? 2 therapists, this is not going to work. In Australia, if you want to have 1 dose of MDMA plus therapy, $30,000 US.
30,000?
Yeah. I mean, of course it's going to go down, but who can access that? Well, if you have $30,000 to spend on that, you can probably do it already. No? So you've gone to Peru, you've done whatever. No? So now the approach is, instead of 2 therapists, let's have 1 therapist. That's still for safety reasons, but I see the next step, which, okay, let's go to group sessions. Maybe 4 people taking psychedelics, 1 nurse, and then 1 therapist that is on call in case that happens. So eventually we might see that the medical field goes to what it's happening already, which is community sessions.
Yeah.
No, like somebody that's holding the space with some facilitators or supporters. You do it in a group setting. They know what they are doing, because that's the truth. People that do ayahuasca sessions and they do mushroom sessions, whatever, these people, some of them are highly trained. They have the empirical knowledge on how to do that, more than any PhD that is doing psychedelic research. So they know how to hold sessions for 20 people. So the model is there already. So I think that one path that needs to be developed is the medical path, and we see how that's happening. But that has a, there's a roof in how scalable that is. So there will be need for community users, and I think that is a type of regulation that we'll need to follow afterwards, in which maybe you don't need a diagnosis to do a psychedelic session. Why should psychedelics only be for psychiatric patients? Can't we all benefit from psychedelics?